I'm talking today with Dr. Bastian Seidel, who is the new president of the Royal Australian College of GPs. Thank you very much for your time this morning.
Thanks for having me.
It's been a busy few weeks because there's been a lot of issues popping up. Is the healthcare homes trial. What's the college's view? Is the trial being given a fair chance in terms of the funding it's getting?
So we are concerned, that the trial is being funded to fail.
Yeah.
And we need to have a look at what we actually want to achieve by introducing a healthcare home or by introducing and promoting what the RACGP calls the medical home.
Yep.
So the medical home it was floated in a position paper that the RACGP published in September 2015. And what the medical home ensures is comprehensive care in a primary care environment in your general practice. And if we improve that, we are saving a lot of money that is currently being wasted in the tertiary care system in hospitals.
Yeah.
So unnecessary hospital admissions, unnecessary outpatient department presentations, duplication of tests and so forth as well. So the idea really is we need to set up the medical home in order to shift excess costs from the tertiary care setting and make that as funding for general practice.
Yep.
And there's plenty of evidence to support it. If we have a look at the details of the healthcare home trials, the way it's being proposed, you don't see anything like that at all.
Yeah.
If you have a look at the detail, it really is about capitation payments for chronic medical conditions.
Yeah.
Not more, not less.
Yeah.
So, I'm sort of wondering, is that really, the medical home still, or is it something completely different? So my concern is it has to become a branding exercise. So again, it has nothing to do with the medical home concept the RACGP proposed. It's something that's being developed by the primary healthcare advisory groups and then those implementation groups the Department of Health will set up.
What did you make of the department releasing all those details late last Friday, including the somewhat controversial suggestion that there would be a 5-visit cap, which they've immediately backflipped on over the weekend? What do you make of all of that?
I was disappointed, and I've been, quite public on that.
Yeah.
It's about healthcare,
Yeah.
so the information has to be transparent and accurate. Healthcare is not meant to be a political sandpit where you can just play around and see what happens. That's not what our patients deserve.
Yeah.
And it's certainly not what practitioners deserve either. And then Monday morning, I think all of a sudden the document then changed.
Yes.
And again, that was certainly the right move. Again, in order for it to be transparent and accurate, it would be nice to say, look, it's now a version 2.0 that's online.
Yeah.
And it would have been nice to be informed of the change as well. Look, the RACGP is going to put a paper out to our members explaining what the healthcare homes is actually involving based on the information that we have.
Yes.
And I think members and GPs have to make up their mind whether they're going to sign up with that program or not.
Like, it's been touted as a trial, 200 practices, and yet it feels like it's the beginning of a rollout. What's your sense of that?
So we've always supported a trial, for academic reasons only.
Yeah.
And if you run a trial, you design it properly, you fund it properly, you have your study group, you have your control group, you have an ethics committee.
Yeah.
You have a safety net for participants who may drop out of the trial as well. That's the way to do. So if you want to do a trial according to scientific academic standards, it's very clear cut, how you're actually going to do this. Now, the way healthcare homes is now, you don't hear trial anymore. If you had a look through the documents, you never see the word trial in the documents. It's implementation phase 1.
Yeah.
So it's very clear. And looking through the documents again, it's very clear that that trial is going to work, no matter what. Rather than saying, okay, let's test it.
Yeah.
See what the outcomes are. And the outcomes of the trial are hopefully informing further policy developments.
Yeah.
That's how you are designing evidence-based healthcare policies. So you run a trial first, you are testing your assumptions, and you move on from there. And that probably would be the academically and scientifically appropriate way to do. Look, I'm hoping and I'm confident that the government and the Department of Health are changing it accordingly.
Yeah.
It can't be in their interest to design health policy on the run. It can only be in the interest of the department and the minister to produce evidence-based health policies. because they are the ones who stand the test of time. They are the ones who improve outcomes for our patients, and they are the policies that inspire confidence in practitioners as well. And that's really quite important these days.
That runs into a question that a GP asked me to ask you.
Yeah.
And I might quote it because she put it quite well. How are you going to maintain a positive public profile for general practice, given the very negative government stance about GPs currently? The atmosphere in GP land feels pretty negative right now, and there is no public recognition of good quality primary care. We feel deserted by the current government, who, despite the rhetoric of "we are listening," it's just not the case.
Yeah, I share the sentiment. It's disappointing.
Yeah.
I'm a practicing GP in Huonville in Tasmania. It's a socially disadvantaged area south of Hobart. And they are the same concerns my patients tell me. It doesn't sound like general practice being valued, and we are constantly being portrayed as the problem. Whereas the evidence is very clear. We're actually the solution of the problems we have in our healthcare system.
Yeah.
Where the main cost drivers are, whether we like it or not, the hospital system. And we need to have a look of how we are getting the money from the hospitals being wasted
Yes.
back into general practice where we know we are efficient. Now, it's not the role of the RACGP as an academic college to get involved in political argy-bargy. We are politically agnostic. We don't have a political message. And it's not my interest to make the RACGP a political organization. It's our role to provide the best evidence that hopefully is going to inform evidence-based health policy. That's our role.
Yeah.
So it's my role as RACGP president to advise the government accordingly when we are supporting policy initiatives and when we disagree on policy initiatives. When we disagree on policy initiatives, and quite frankly we've done this now for quite some time,
Yes.
I'm going to give reasons why that is.
Yeah.
And whether the government listens or not, that's really not up to me. That's a political choice.
Yes.
And government has to take political responsibility for that as well. The difficulty is in health policy is that if you have failed health policy, it's going to harm patients. So patients who can't access their GP and they're unwell and they're delaying a presentation because they can't afford it, they're doing harm to themselves.
Yes.
How do you justify that? And you could argue, GPs are making a lot of money and they're always complaining, but the evidence yet again doesn't support it. So if you have a look at the Australian Taxation Office in terms of, average income per year, you realize that the average income per year of a GP is now less than half of what a hospital specialist would earn.
Yeah.
Now that's not really that important because we knew this beforehand. So I'm not a GP in Huonville because I'm in it for the money.
Yeah.
I'm in it because the GP, the community deserves to have a GP. I think it's a common sense approach. But having a Medicare rebate freeze over years, having it extended,
Yeah.
having zero support in any other ways, and then being targeted in the media as cost drivers, talk about bulk billing and incomes and so forth.
Yeah.
I understand the GPs are disappointed. Now again, the federal government hardly spends anything on general practice.
Yep.
So, if we include primary health networks even for the general practice funding, it's $7.1 billion every year. If we take this out just for Medicare funding, including practice incentive payments, it's $6.5 billion every year. And people think, oh, that's a fair bit. Now we have 24 million people in Australia. 86% of the population sees their GP at least once a year. So the cost of Medicare general practice per person per month is $28.20. So that's less than a subscription to Foxtel. And that figure has been steady over the last 10 years.
Yeah.
Hasn't changed. So never mind whether people say, oh, people see their GP more often, never mind, what else is going on. Well, the cost is the same to the government, so it doesn't really matter.
Yeah.
Whether somebody sees the GP twice a day or 10 times a day, as long as on average in Australia for 24 million people, the cost is $28.20 per person per month. What does it really matter? And it's got to be understood. On this, so as I said, federal government spending $6.5 billion on general practice. If we look at how much the federal government spends, for example, on the subsidy for private health insurers,
Yes.
that is $6.1 billion. So it's pretty much the same amount.
Yeah.
But private health insurance is only available to less than 50% of the population.
Yeah.
So why not funding Medicare for general practice? That would affect, over 86% of the population every year, rather than putting this to private health insurers. Now, not only are they paying $6.1 billion as subsidy, that subsidy is also indexed over the next 4 years.
Yeah.
And it's indexed not at CPI, it's indexed at 4%. And that doesn't make any sense. So on the one hand, you appreciate, there's a subsidy for private health insurers and you index that.
Yes.
But when there's a subsidy for people who want to see their GP, that's called Medicare.
Yeah.
You are not going to index that. So for private health insurers, you index that at 4%. Why not saying index that at 2%? Which is CPI.
Yes.
So you have 2% spare. Now, the spare money you have, it's $180 million every year. Why don't put this then to lift the index freeze for general practice, which would be exactly the same amount?
Yeah.
So it wouldn't cost any money. It would just shift the funds that are available now and budgeted now from an area that's available only to a few people to an area that's available to each and every Australian. So that's the sort of advice we have been giving the health minister, her advisors, the department, and the Prime Minister even.
Yes.
Well, the outcome so far, nothing has happened.
Yeah.
Now, again, I'm not making up this stuff,
No.
that's out there now. The data is out there now, and by all means, have a look at the budget papers from May and have a look at the final budget outcome statement. So the money is there, the data is there. Let's have a common sense approach when it comes to health policy for general practice. And let's implement those policies. And if you don't, then you're doing it for political reasons.
Yep.
And look, there's nothing I can do about. That's something I can comment on. But again, that's the role of the RACGP now. Continue to inform on best practice, continue to inform on best health policies. But that's of course just a sideshow, because the main thing for us is, standards and education for GPs, which is still the main domain.
Which brings us to the CPD reforms.
In every triennium, or before each and every triennium, or way before each and every triennium, we are looking at how we can improve our CPD program.
Yeah.
And plan is nothing else but a reflective quality improvement component, or quality improvement exercise. And the evidence behind it is that if we focus on reflection as practitioners, we actually do improve outcomes for our patients.
Yep.
And we just become better doctors on the way. I think it's quite nice. So I think
Yes.
it's a win-win. The RACGP tried to introduce reflective learning plans really seven years ago. And we had a paper-based approach first. And that didn't really quite work out for many, many reasons, because nobody wants to use paper. And in particular over triennium, you're losing that. Nobody keeps it over 3 years' time, and it was really quite difficult to do. So we dropped it, and again, we reconsidered using it, and we said, look, the moment we have a better online environment and better IT, it's something we need to consider again.
Yep.
So it's always been on our mind for obvious reasons. So again, it's nothing new there, and again, the evidence backs it up. Come revalidation, and there was this interim report on revalidation published out of nowhere on the 16th of August, I believe.
Yes.
This year it was, with the component that colleges are meant to strengthen their CPD programs. And one of the major components was a reflective tool. So when the medical board report came out with a strong emphasis on reflection as part of CPD, we actually had to decide, with our new triennium coming up, are we going to introduce it now, which is January, very short time frame?
Yep.
Are we introducing within the triennium as an option, or are we introducing that for 2019, 2020? There are the 3 scenarios we had, and there were pros and cons. Now the medical board then says, okay, we published the report in August 2016. We are focusing on reflection and enhanced CPD. We are consulting with the profession. In 2017, we are starting pilots.
Right.
We want to know how you do it. So we as as an academic medical college, decided, okay, if we want to shape revalidation, if we want to get ready for our members to make sure that if you are signing up with the RACGP CPD program, you are covered
Yeah.
and you are actually in line with what the medical board is going to tell you to do no matter what. We probably don't have any other choice but to get started in January. Because if we were starting in January now and make it compulsory rather than optional, we could demonstrate to the medical board really quickly, if they wanted,
Yes.
how reflective learning has made a difference. Now, I've no doubt it's going to make a difference. The evidence is too overwhelming based on international experiences there. But for members, it's going to be important, because if the medical board calls you and says, can you demonstrate how your enhanced CPD worked for you? The member has to say, okay, that's what I did, that's how it worked for me, and here's my reflective exercise.
Yeah.
And RACGP members and RACGP CPD participants will be able to do this.
Let's look a little more broadly. We're on the brink of a new triennium. Where would you like to see general practice primary care in 3 years' time?
General practice has to be the solution to the problems we have in our healthcare system, because it is.
Yeah.
It's just not being perceived as a solution. In order for that behavior to change and for the perception to change, we just need to educate the public better. And that's what we've been doing as the RACGP with our brand awareness campaign, which we know has been very effective amongst the public. And we need to be closer to political decision makers. So whenever it comes to health policy discussions in respective party rooms, I want politicians to be informed.
Yes.
Not by lobby groups that are in for a financial interest no matter what. But I want them to be informed so the electorate feels the politicians are looking after them when it comes to health. Because if your voters aren't healthy, there's not much point talking about employment opportunities and so forth, education opportunities, because they won't be able to attend either of them. So health comes first, and we need to prioritize that. So within the health spectrum, general practice, of course, should be left and right and center, because that's where we are. That also is some education for other professionals within the health spectrum. And I appreciate my hospital specialists and pharmacists and allied health practitioners. But again, we have to stand our ground. That's what our members expect. And quite frankly, that's what our patients expect us to.
Yeah. Thank you for your time today.
Thank you.